Welcome to our webinar series for professionals.
So welcome everyone to this very exciting webinar in regards to hormones and fertility. So with Dr. Smeaton today. And just before we start, I just wanted you to pay attention to this education site that we have, so you always can look into what we have of education. So I'm just gonna share my screen with you and show you how you find it if you can't find it right away. So let me just share my screen here with you. There. So I'm in the VMS account that most of you should have, and if not, please let us know so that we can make sure you have access to it. And then I'm going into the menu here called Education. So that's the one that I've clicked on here, and you can see that all these webinars that we offer, this one, we know this person here. She's gonna do some talking today. And education. So you can always find the webinars that we have recorded. They are here as evergreen recordings. But up here in the right-hand corner, there's a little button that says New Training, and it takes you onto our Nordic education website, where the more in-person webinars are, or if we have put in several hours of training. I know a lot of you attended the organic acid basic training with Umaro, either in Danish or in English. And if you didn't attend live, you have the option of purchasing the recordings for sure. Then there's a few seats left for our Copenhagen event, November 1 to the 3rd. So now is kind of the last chance. I think we will be completely sold out. So please join us. We just want as many people there as possible. So because we think it's just fun to connect with as many people as possible as well. And then it just scroll down and you can find a lot of the DNA recordings, webinars that we have. And then also we have, if you want to, if you're a little bit north and you want to get some sun, then we have the DNA Life certification course in Dubai in 10 days. So that's just around the corner. So I just wanted to pay your attention to this, because then you always have a go-to in our system where you can check out under the education menu what's there, what's available. But there's so much free content as well that you can dive into if you feel bored. So that was just what I wanted to say. I hope you're all well out there, settled with some tea and something so that you're cozy and comfortable, and some pens and some notepads, and however you do it. That was kind of the old-fashioned way. Of course, we just use AI to do our notes now. So, but Dr. Smeaton, why don't you come up and tell a little bit about yourself and move into the actual presentation that you wish to share with us.
That sounds great. Thanks, Anne-Catherine. So thank you so much. I'm just going to get my sharing done here first to make sure that everything goes perfectly here. All right, so you should be seeing my title slide. So this is a really close to my heart presentation. I am the Chief Medical Officer for Dutch Test, and I've been there for 2 years. But really, my entire career as a naturopathic physician for the last 20 years has been focused around helping couples with infertility. And that's really where I came upon using the Dutch Test as a practitioner before coming to work with them quite a number of years ago, really when they were first getting started. I met them at a fertility conference in Vancouver, British Columbia. I was a speaker, they had a booth, and I remember meeting their team and just being really impressed by the science behind the test. And they didn't have a lot of education developed at that time because they were so new. So I really had to learn how to utilize the test in my own practice. But I love talking about this because this is what I've done with my patients for the last 10 years, is really applying the Dutch test to look at hormonal complaints. We're going to talk about that because, of course, hormone imbalance is a huge contributor to infertility. But there's so much more that you can learn from the Dutch test that I think today you're going to walk away with some additional insights as to other markers that you may not have really been paying attention to, that you might find to be really helpful when you're working with this population, both for men and as well as for women. So let's go ahead and dive in. So just to kind of level set, the definition of infertility is the absence of pregnancy or delivery of a live-born child after 1 year of unprotected intercourse. Now, of course, today we have a lot of people attempting pregnancy a little bit later in life. Over the age of 35, you're considered eligible for a workup in the United States if you've had 6 months of unprotected intercourse, because they don't want to allow things to go too long. But really, we do an evaluation at any age if there's any kind of known or suspected barrier to pregnancy. So some things that might trigger that might be a family history of infertility or a personal history of other relevant medical concerns. Or you've had a year of timed intercourse if you're under 35 years old, or 6 months of timed intercourse without pregnancy if you're over 35 years old. So the standard evaluation is where we always start, myself included. This would be that we are documenting that the female patient is ovulating. We can do this sometimes through looking at the patient's history. Do they have regular menstrual cycles? But don't let that fool you, because some women, that probably about 10% of women who have regular menstrual cycles, are not ovulating. So the presence of regular menses is a great sign, but it's not a guarantee that ovulation is occurring. So what we look for is measuring progesterone in the mid-luteal phase. So that would be cycle days 19 to 21 for a patient with a 28-day menstrual cycle, really the same timing that we use to time the Dutch test. And you look for that level to be greater than 5 nanograms per milliliter. We also, for the female patient, order a hysterosalpingogram or HSG. This makes sure that the fallopian tubes are open. And what they do is they put a dye into the uterus, and then they can watch it It's a dye they can visualize on CT scan, and you can watch it spill into the abdominal cavity, showing that things can get from one place to the other, which would indicate the fallopian tubes are open. We also do an assessment of ovarian reserve. I use the words egg quality and ovarian reserve interchangeably, but this is a really important piece, absolutely, for women in their mid to late 30s or older who are trying to conceive. This is the biggest barrier to pregnancy that I work with in my own patient population. However, it is something you should also be considering for younger women, because we are seeing a lot of younger women who have a reduced ovarian reserve. Okay. And there's a lot that's causing that. Probably environmental toxins is our biggest contributing factor, along with stress as another factor. But with environmental toxins, what's very interesting is that exposure in utero can impact that next generation. So when we think about the women who we're treating today, they were in utero at this point, really in the 80s, the mid 80s. And at least in the United States, that was really the 70s were when things really peaked in toxicity. We had industry and businesses like dumping their waste into our rivers. And it wasn't really until the early 1980s that the United States government got involved and got more regulations put in place and more cleanup efforts put in place. And even still today, there's a lot of contamination of water supply, food supply, et cetera. So something that could be impacting them even from when they were embryos, their own embryonic development. There's a lot of ways that ovarian reserve can be assessed. Generally, we do blood work on cycle day 3. So cycle day 1 is the first day of menses. So cycle day 3 is normally within the time that they're on their period. And you can measure follicle stimulating hormone with estradiol. That's the most commonly used measurement. The next would be adding anti-mullerian hormone, or AMH, which is, not very accurate or predictive, but it gives you another way to kind of look at ovarian reserve. There's other things as well, like ultrasound, that can be done to see how many follicles are developing. That's called antral follicle count. So that could be added if you wanted. And then there's a couple additional lab tests like inhibin, which aren't as commonly run, but can add to that picture if it's not clear from those original tests. And then lastly, some women will have a laparoscopy completed. This is normally done when there's an abnormal pelvic exam or an abnormal HSG, or the patient has suspected endometriosis. Okay. And then I skipped that second bullet, standard semen analysis, but it's really critically important that when you're working with a couple to help them conceive, even if it's the female patient who comes to your office and who requests the workup and who is really engaged, it's critically important that you also test the male. And the male partner's workup is actually, because we can measure the endpoint, which is semen analysis, it's so much easier than it is for female patients. So in my practice, I'm insistent that if a man has not had a semen analysis completed, we really won't go beyond blood work for the female partner until we collect a semen analysis, because it's about 40% of the time that it's a male factor in fertility, about 40% of the time it's female, and then the other 20% of the time it's combined. So really what that says is about 60% of the time male fertility is involved. About 60% of the time female fertility is involved, and there's an overlap there. So we really do need to look at both. And I see a lot of providers, particularly in the integrative space, who usually because the patient expresses discomfort or for whatever reason, they bypass that. And we really can't do that. Now that's kind of the standard test, but there is this whole world underneath infertility, which I would say is like the physiology behind, or the pathophysiology behind infertility, that's so important to understand. And before we get into the details of that, there's been some interesting research in the last couple of years published, particularly around men, that fertility is really an early indicator of bad health for males. And the data is so strong that infertility in the 30s is related to increased all-cause mortality for men, that there is starting to be a recommendation that semen analysis become part of a wellness screening, even for men who are not trying to conceive, because the health of the semen, the health of the sperm, are indicative of a wide variety of underlying problems that end up leading to infertility early, but then end up leading to metabolic dysfunction and cardiovascular disease and diabetes and cancer and all of these other problems down the line. I'm not going to talk about that today, but if that's something that's interesting to you, there's a lot of information out there available. It's almost like I would call it the canary in the coal mine. It's the first sign of a problem in long-term chronic health. And it's likely that it's the same for women. So when we do an evaluation for patients, we want to do a thorough intake. I like to also, on top of a standard fertility workup, look for signs of underlying physiological problems, the things around gut health, chronic infections, problems with detoxification, problems with energy production, problems with high levels of oxidative stress, immune imbalances or inflammation, hormone imbalances, and then, of course, structural abnormalities like endometriosis and fibroids. It's so important to take a look at everything that's going on. Now, I love this. This actually came from Dr. Kara Fitzgerald, who is a functional medicine naturopathic doctor in America. She's in Connecticut. And I really liked this kind of organization that she did. This is related to IFM, the Institute for Functional Medicine's Functional Medicine Matrix. But really what she did was look at what she observes clinically. Hopefully you can see my cursor. What she observes clinically in the office, what lab results she sees, and then what that is related to as an underlying pattern or cause. So you can see those are like nutrient imbalances here. So these would be signs and symptoms of that. Defense and repair, so immune imbalances, inflammation, infection, and dysbiosis. These are things you might see. Problems with digestion, respiration, absorption. These are things you might see, and so on and so on. You can see there's endocrine abnormalities here, mitochondrial dysfunction here under energy, and then mental, emotional, and spiritual. And really what I like about this is that I think you can apply that to the fertility space to start to categorize what is happening with that patient and what might the underlying physiological patterns be that you see. And I'm going to give you my own version of Dr. Fitzgerald's chart related specifically to fertility as a takeaway for you. Now, this paper was one of my favorite papers to come across. It was published in OncoTarget in 2017, and it was a paper about unexplained infertility. Now, unexplained infertility actually affects about 30% of couples who get worked up for fertility. And this is when there's no clear diagnostic problem. It's not low sperm count. It's not endometriosis. It's not PCOS. It's not anovulation. And they really, when they do the testing, things look quote unquote normal, and they can't determine why a couple's not conceiving. So this paper was a review, and it looked to break down all of the things that have contributed to unexplained infertility. And it suggested that it ends up being a combination of factors that are mild but affect multiple areas. So you can see on here, poor egg quality, poor sperm quality, embryo toxicity would be, problems with the DNA in the embryo. And then receptivity of the endometrium and implantation failure, meaning that the endometrium isn't a healthy environment. That could be due to low progesterone. It could be due to inflammation. It could be due actually to microbiome imbalances within the uterus. There's a lot of new data on that. But then when we look at what leads to these 5 contributors to infertility, you see a lot of patterns that we look at for other conditions as well, like hormone imbalance, oxidative stress, inflammation. And from inflammation, you have imbalances in cytokines and chemokines or altered immune cell function. So when we start to overlay the physiology of the whole body, what we can start to see is that some common patterns and common contributing factors that cause disruption across many of these causes for unexplained infertility, like environmental pollutants, the presence of endocrine disruptors or heavy metals, that can lead to hormonal imbalance. It can lead to oxidative stress and certainly a lot of inflammation. Or problems with gut health, which can affect all of those. But then also, we do know that there's a reproductive microbiome. That's something else I'd love to teach you about in the future. And Catherine, take a note. We can talk about that someday. But we know that not just the gut microbiome, but the microbiome in the vaginal vault, in the fallopian tubes, and especially inside the uterus and inside the endometrium will contribute to success rates with implantation, with IVF, and miscarriage rates as well. So gut health is critically important. Stress and adrenal function, because when that is off, it can touch a lot of these areas. Also, poor nutrition can affect a lot of these areas. And then when we look at things like autoimmunity and inflammation and overall immune balance, you see how the impact, it ends up touching many of these different areas. So we really want to make sure that we're assessing all of these contributors to overall health and wellness when we're doing a fertility evaluation, especially when all the first run labs look normal and you're really trying to dig a layer deeper to get to the root cause. So I told you that I had looked at really what I tend to see when it comes to fertility from that functional medicine perspective. Now, when I look at all the different physiological areas that I want to assess when I'm meeting a new patient, here are some of the signs and symptoms. I've combined here lab testing that I might see as well as signs and symptoms that would lead me into testing a specific area a little bit further. So you can see for gut health, of course, gas, bloating, pain, diarrhea, constipation, history of antibiotic use, etc. You can see infection. I might want to screen for infections, detoxification, energy production, which would be including mitochondrial health, oxidative imbalance. This is probably the biggest one, which is high levels of oxidative stress, which cause cellular damage and DNA damage, inflammation, hormone imbalance, and structural problems. And then I've included on the right-hand side some of the tests, and it's not all Dutch tests, but I've included a lot of the Dutch test analytes that I specifically look at when I'm wanting to assess that physiological area. And we're going to go into that in more detail, but I love to provide for you some slides that you might be able to print out and like tuck away for quick reference. And we have a couple of those for you in here. So I did also want to share with you, this is a Dutch resource. We did pull together kind of the patterns that our clinical team observes in patients with high inflammation. So this is a new reference. We have these things called mini guides that we put out, and I'm not sure, Anne Catherine, if we have them out with you yet, but we're happy to share them. We have about 19 that we've made for the most common conditions that practitioners order the Dutch test for. So we have one on inflammation. We also have one on infertility, which I'll show you towards the end. But really what this acts as is a checklist that if you suspect inflammation in your patient, you can go through their Dutch test and see, do I see high estrogen? You can check it if you see it. Do I see poor phase 1 detox? We tend to see a high 4-OH when there's a lot of inflammation, or a high 16-OH. You might see low DHEA sulfate, a shift towards 5-alpha preference. The biggest area that we see that shift is with cortisol, the THE and THF metabolites, but you might also see it with androgens. You might also see it with progesterone. But the strongest correlation is with the cortisol metabolites. Any abnormal cortisol findings, lots of stress, cortisol metabolism issues, and then you can see a lot of the different oats that we have on the last page of the test are related to inflammation as well. So again, this is a great takeaway for you that if you want to take a look at your patient's Dutch test and look beyond just hormones, you can actually take a look to see, do they have the patterns that suggest that they might have chronic inflammation as a piece of their picture. Okay. These are the things that our team, our doctor team picks up on really commonly when we're doing consults. And so it's nice to be able to pull it all together so that you guys can take a look at your own tests and see if these are going on. And I would go through the checklist and literally check them off. If you're seeing more than 50 or 60% of these, it's likely that inflammation's a piece of your patient's puzzle. Okay, so let's talk about what you can assess with the Dutch test and how that's related to fertility. So the first piece is hormonal balance. Now, of course, this is one of the most important aspects to fertility because a proper cycle and proper hormone levels are needed to mature an egg, to ovulate, to support implantation, etc. So with Dutch, you can look at sex hormones and sex hormone metabolites. And I've also already covered some serum labs that I recommend you order if that's within your scope and you're working up a patient for fertility. So here are the areas that I look. So on the summary page, you can look at the top of the summary page to see the main sex hormones, estradiol, progesterone, and testosterone, to get an idea of where those fall. Now with estrogen, I'm going to go through these pretty quickly, and you have this as a reference. And also this information really comes out of our interpretive guide, which I know you have access to. That's a fabulous guide where you can look up your patient type. In this case, it'd be a cycling female. Look at the hormone, look at high, low, and normal, and learn everything you need to know about what could be going on with that patient. But if estrogen's high, remember, this is a luteal phase measurement, not a follicular phase measurement. It could be normal. That could be their normal. So you have to ask, do they have signs and symptoms of high estrogen? I would be looking for heavy bleeding, cramping, fibroids, breast tenderness, etc. And if they do have that estrogen dominance picture, I'd be looking at outside exogenous estrogen exposures, maybe high aromatase activity, especially if their androgens are low, poor detoxification of estrogens. And then there are some underlying factors like insulin resistance and obesity, inflammation, even elevated androgens. So like women with PCOS tend to also have high estrogen because that's an elimination route for androgens. Excuse me. And if it's low, you could be associated with high stress, thyroid dysfunction, etc. I always like to ask if patients are on DIM, because DIM can lower estrogen, so that if it's low, you might want to get them off of that or double check any supplements that interact with estrogen. And if it's low, oftentimes you'll see it paired with things like low libido, vaginal dryness, hot flashes, etc. Now, when you look at estrogen, this is on the sex hormone page of the report, you can see estrone, estradiol, and estriol. So in this case, this patient's obviously extremely high. Now let's look at progesterone. Again, progesterone when it's high can be normal and it's normally asymptomatic. High progesterone can also be associated with supplementation, with pregnancy, good one to check for in this population, inflammation, HPA axis dysfunction, and insulin resistance. And the ideal mid-luteal progesterone in serum is above 15. Keep in mind, in the United States, we have access to progesterone as a topical cream over the counter. And I see a lot of integrated providers recommend that. And it doesn't really actually have that great of an absorption, so it might not increase serum levels, but I see progesterone used kind of liberally, and there is an upper limit to how much progesterone you want. Studies do show that serum levels over 41 actually lower pregnancy rates. And so really, once you're in the 15 to 20 range in serum, you're good. Okay. When progesterone is low, that's more problematic. Oftentimes it's a sign a woman's not ovulating, but it can also be related to high stress. It can be related to perimenopause, thyroid disorders, etc. And it's oftentimes paired with symptoms like fatigue, irritability, insomnia, especially. So you can see progesterone here. This is on the sex hormone page. It's in the upper right-hand corner. And we show progesterone. In this case, this patient looks very adequate. And then you can see the breakdown into alpha and beta pregnenolones. Now, the alpha and beta pregnenolones are what we measure in urine. We can't measure progesterone itself because progesterone doesn't show up in the urine. We see progesterone after it interacts with cells and it gets metabolized and it gets excreted. And that's as the pregnenolones. But we're able to calculate a serum level based upon the pregnenolone levels in urine. So what you see reported above on progesterone is a weighted average of the metabolites that are below. Okay, testosterone. Now, we might not always think about testosterone in females, but it's really important for females. High testosterone is commonly associated with PCOS, low sex hormone binding globulin, low aromatase, but really associated with stress, obesity, blood sugar dysregulation, and inflammation. Now, one of the reasons why we see it associated with stress is that DHEA is made by the adrenal glands, just like cortisol. And so when the stimulation of the HPA axis goes up, that stimulation by ACTH drives cortisol to be released as well as DHEA. So when those are dysfunctional, it can actually affect DHEA production. And then you don't have enough of the precursor hormones in the pool to make the androgens that you need. When androgens are high, you might experience acne, facial and body hair, thinning scalp hair, and irritability. Or when it's low, you might see things like fatigue, weight gain, mood changes, low libido, etc. Now in males, similar symptom picture. And I think the only thing I want to call out is when you're doing a Dutch test in males, you do want to make sure there's adequate androgens because androgens are really critical for good sperm health as well as egg health. Now, if men are on testosterone replacement, just know that that can have a negative impact on sperm production. So that testosterone should not be used in men who are trying to conceive. There's other options like Clomid, which is clomiphene citrate, or using testosterone in combination with human growth hormone or HCG to help to balance that out. So there's other options available, but if you give men testosterone replacement, it'll actually shut down sperm production in the testes. And you can see testosterone, this is the female report here on the left-hand side of that page. You can see in this case, well, this is actually probably not the best example because this patient probably has a UGT deletion. Normally you'd expect low would probably be around here, but it's this low. This could have been a genetic SNP where that patient doesn't dump testosterone into their urine. Relatively rare, but we see it once in a time. Now, the other element of hormones that we look at is estrogen detoxification, another really critical piece to look at. You can see this on the sex hormone page. I showed you these estrogens already. And then below that, we have these 3 arrows and dials, which talk about our phase 1 metabolism. This is hydroxylation of our estrogens. And then after that, you look right here for phase 2, which is methylation of the hydroxylated intermediates. You'll see there's 3, 16, 4, and 2-OH. And generally, we want to have patients metabolize the most through the 2-OH pathway here. Okay, so this is phase 1. Now, phase 1 occurs mostly in the liver. And like I mentioned, you add the hydroxyl group. Now, the intermediates that are made are really reactive, and they need to be further transformed in order to be excreted. And that requires good liver function. Alcohol use can impede, medications can impede. It also requires good iron. Now, I mentioned there's 3 main metabolites, the 2, the 4, and the 16. Our team calls these the good, the bad, and the ugly, okay? The good, the 2, is the least carcinogenic. We consider it the most preferred pathway. The 4 is more carcinogenic. And if it doesn't metabolize through phase 2, then those reactive metabolites can become a free radical called quinones, which can damage DNA. And those are very relevant for patients with infertility. The 16, or the ugly, is actually proliferative. So it's really good for things like bone health, but not so great for women that have breast issues, fibroids, endometriosis, etc. And then when we look at phase 2 on the bottom, like I said, this involves methylation and it involves the COMT gene SNP. And methylation is critically important. What we have is these estrogens get a methyl group added by COMT, and it leads to production of 2 and 4 methoxyestrone and estradiol. And from there, those get conjugated with glucuronic acid and sulfate in the liver. That makes them more water soluble. It packages them up, and then it supports excretion through bile into the gut. Okay. Now, the next phase of detoxification, or phase 3, is where estrogen metabolites leave the liver through bile, and they're excreted through feces or urine. Sorry about my barking dogs here. Give me just a second to get them to quiet. Okay, so in the gut, there is an enzyme called beta-glucuronidase. It can be found in tissues like breast tissue, but it's also made in the gut by the microbiome, predominantly by dysbiotic microbes in the gut. And when it's made in the gut, those estrogens can be recirculated rather than excreted, and that can cause an increase in the overall estrogen load. Okay, so here again, I like to just summarize for you that kind of quick takeaway. And what I've also included for you here is how to help. So if you see poor phase 1 metabolism, some things you can think about are ensuring good liver function, making sure the patient's iron status is adequate. And you could think about adding things like DIM, indole 3-carbinol, quercetin, and sulforaphane. Now, if the issue is phase 2 methylation, and we see this all the time, then adding things like sulforaphane can be helpful, but also methyl donors. So SAMe, choline, magnesium, trimethylglycine, and then your methylated Bs can be really helpful. Now, there are some things that will inhibit that methylation pathway. Estrogen dominance or gut infections are some things you might want to treat. Heavy metal toxicity, BPA exposure, but also green tea and quercetin, which if you have the patient on that for another reason, you might try pulling that back and then retesting to see if that helps as well. Now, if the problem is with phase 3, getting it out of the liver, into the bile, into the gut and out, like if the patient has infrequent bowel movements or signs of estrogen dominance, you really might want to start with improving the microbiome. Make sure they have a bowel movement every day, thinking about increasing water and prebiotics. There's a really great study on unpeeled raw carrots being excellent. You can even grate them and make a salad out of them. They're quite delicious, but that can be a really great way to improve the prebiotic fibers in the gut. Okay, I want to talk next about oxidative stress. Now, I mentioned this is one of the biggest, most important pieces for fertility because it's one of the key drivers for cell damage, and egg and sperm are both really easily affected by oxidative stress. Actually, sperm are probably the most sensitive cell to oxidative stress, which is why men make millions and millions and millions because they're so easily damaged. Now, there's a couple of markers on Dutch that you can use to actually measure oxidative stress. So my favorite one is at the bottom of the last page, the 8-OHDG. This is 8-hydroxydeoxyguanosine, and this is a measure of oxidative stress and DNA damage. So this is actually more of a direct measure of oxidative stress. If this is elevated, that's really problematic. There's other areas that get damaged before DNA. So if you see 8-OHDG high, that patient has a really high oxidative load. A couple of others that I like to look at are pyroglutamate. This is a marker for glutathione. If it's high or low, that can indicate a deficiency in glutathione. Now, glutathione we make ourselves. We make it from precursors like NAC, but it is something that we should be making enough of, but there can be an imbalance of that. And there's also genetic SNPs that make it tougher for some people to manufacture their own glutathione. So if you see pyroglutamate out of range, you might think about adding glutathione, adding N-acetylcysteine, and working on just that patient's overall exposure to antioxidants. Okay. Now, the last one that might surprise you is melatonin. Now, melatonin, you can see in this patient's example, the patient's actually supplementing with melatonin, which is why it's so high. And the reason why they're supplementing with melatonin is that there's great studies on melatonin being a therapy to treat infertility because it actually can improve egg quality. Now, melatonin itself is a great antioxidant. So we make it to sleep, but even if someone is sleeping well, they might benefit from extra melatonin. But absolutely, if they're deficient in melatonin, that can be problematic. And you want to make sure that you're supplementing that. The typical dose is just the 3 milligrams before bedtime, the same thing that you might give for sleep. But studies in other health models like cancer and oncology use about 20 milligrams per day before bedtime. So that's been studied and been shown to be safe. So you could really go up if you wanted to, although I think there's lots of other antioxidants that could be helpful. Okay, so we've covered like immune balance and inflammation. We've covered hormonal imbalance. We've covered oxidative imbalance. So really, when you're looking at assessing a patient, you really want to make sure you're looking holistically at their picture to determine, to determine where you want to look next. Now, I want to talk a little bit more about inflammation and immune balance. So immune balance is critical for fertility. It affects our hormone levels, our capability to detoxify. Now, think about implantation. Now, when implantation occurs in the endometrium, the embryo is actually foreign tissue to the mom because it has half of the genetics from a paternal source, whether sperm donor, father, etc. So the mom's immune system should be able to notice that that's abnormal. It's not self and attack it. But there's a lot of evasive control that goes on and a lot of interesting immunology at the early time of pregnancy. So it's very sensitive. And if things are off, like in cases of autoimmune diseases or dysbiosis, like I mentioned, it can really throw things off. And even a small amount of inflammation in the uterus can cause trouble with implantation. So I'll talk about Dutch, but other labs you might think about for immune balance and inflammation might be high sensitivity CRP, sedimentation rate, looking at anti-nuclear antibodies. Now that's fertility studies say don't look at them, but certainly they are a sign of early autoimmune activity going on in the body. And we do know that certain autoimmunity, like thyroid autoimmunity, like anti-thyroglobulin, if that's elevated, that's aligned with infertility patients. And not really sure why. There could be some cross-reactivity in the ovary, but we do know that if women have elevated thyroid antibodies, even if the thyroid is fully functional, they have a higher likelihood of having infertility. So any kind of autoimmunity I want to know about in my practice because we can address that through lifestyle and through supplementation. Okay, so I've shown you that chart, just a reminder of some of those common patterns that you might see with inflammation on the Dutch. Now, the next I want to talk about is toxic exposures and detoxification. Now, toxic exposures can affect fertility in a number of ways. It can affect cell health directly, causing damage to sperm and egg. There's fabulous data on this with everything from BPA, which probably has the most data, phthalates, but even things like non-ionizing radiation from cell phones or anything plugged in or with a battery. Now there is more and more data coming out, really just in the last 10 years, but it's really been mounting, showing the impact of all of these toxic exposures on fertility. Most studies are done on men because it's very easy to measure semen analysis before and after exposures. There's also interesting studies on farmers where farmers tend to have more babies, like they conceive more out of season. So they conceive more in like February and March when they've had some time away from pesticide sprays. And then they end up, giving birth later on in the year. Really interesting data around that. So certainly an area that we want to be thinking about. Now, when it comes to Dutch, I always am looking for signs of inflammation and oxidative stress and asking the patient about their history to try to determine whether toxins are a big piece for them. Also with toxic exposures, I tend to see a shift towards an estrogen dominance type of pattern, although not always, but that's something else that might clue me in to say, okay, we should maybe do some more testing. Now, there are lots and lots and lots of toxin panels available in the market. That's not typically where I start because I think you're going to find something if you look, and it might steer you down the wrong path. And generally, the way I would treat is through avoidance. So I just educate all of my patients around avoidance. And unless I think there's really risk of like heavy metal exposure or something, then I might do more specific testing. Now, this has been one of the most helpful tools that I've used in my own practice. This comes from Dr. Joe Pizzorno. He was the founder of Bastyr University, which is my medical school that I went to. And he's dedicated his whole life to studying toxic exposures. He really studies it primarily in the realm of metabolic health and type 2 diabetes. But he wrote this great book called The Toxin Solution. It's a consumer-facing book. But really what he's found is that a lot of conventional, standard, low-cost blood labs have really strong implications for showing who has greater toxicity or who is at a likely risk of toxicity. You can see them here. This is a chart that I made for my own practice based upon the screening research that he's done. The most impactful one here is definitely GGT. If you only could measure one, I would choose GGT. But if you can run this whole panel, you can see where they fall. But look at what is so interesting is that the normal range at a lab says for GGT is 10 to 50 units per liter. Now, the data shows, published data shows that even in the normal range, patients at the high end have an incredibly high risk of toxicity. It's only those in the lowest, 20% or lowest 10% that really seem to be clear of toxins. So it's a really great indicator and a good idea to help guide you as to what patients might even need further testing. Now, if you don't want to use a blood screening, there's lots and lots of questionnaires available. This one comes from Institute of Functional Medicine, but there's so many out there where your patients complete questionnaires. Do you consume canned or farmed fish? Are you exposed to toxic substances at home or work? Et cetera, et cetera. And there's a scoring system that will help you find the patients who might be at highest risk. Okay. Now, one thing I'd like to mention is on top of inflammation, the process of sulfation is really critical in order for us to detoxify hormones, but also toxins. So when we look at people who are struggling with detoxification, it always makes me think about checking their ability to sulfate. It's also really important, sulfation, in order to kind of compensate for free radicals and quench free radicals. So that sulfation requires a lot of nutritional pieces like methionine and cysteine, which are both sulfur-containing amino acids, along with SAMe and glutathione. And some of the things on Dutch that we see that points to potential problems with sulfation is low DHEA sulfate relative to total DHEA, of course, because DHEA sulfate is the sulfated form of DHEA. We also tend to see elevated 16-OH compared to 4 and 2, elevated E3 relative to E1 and E2, and low melatonin. So if you see that pattern, you might be thinking that your patient needs a little bit more support for sulfation. Okay, mitochondrial health. Now, the mitochondria are critically important for all healthy cells, but egg and sperm especially. In fact, egg and sperm, or like the epididymis and the sperm cells and egg cells, have about 200 times more mitochondria per cell than any other cell type in the body. Okay. Also, early embryonic development, the replication and replication of those cells is very energy intensive. So we need really healthy mitochondria. And this is probably why we start to see fertility decline so much with aging, because of course we know many people undergo these changes with poor mitochondrial health. And there are some markers on Dutch that can point to that. So high 8-OHDG, pyroglutamate being high or low, because keep in mind mitochondrial function and oxidative stress kind of go hand in hand. You could also think about testing for nutrients that are critical for mitochondria, like CoQ10 is probably the one that jumps to mind. Okay, gut health is next. So why is gut health important? Now, GI function can contribute to inflammation and oxidative stress. It can affect hormone levels. And also, of course, we want to look at microbiome health. Now, actually, with Dutch, we can kind of get a little bit of an indirect look at gut health, although we're not intended to be a gut test. But we did add a marker called indican, which is a urine marker that will go up in instances of dysbiosis. Not all instances, it's not super sensitive, but we can measure it. So we put it on there because if you see that elevated, that's a patient that you should do a further gut workup on. You also might see elevated estrogen levels, like I'd mentioned before, because of dysbiosis in the gut, having higher beta-glucuronidase and more recirculation of estrogens. Now, if you suspected gut health due to these being elevated or signs and symptoms that come from your patient, then you'd want to do a broader GI panel or a microbiome assessment. Now, just a couple other considerations. You might want to think about generally testing the microbiome. The GI microbiome definitely is easy to test now. Also, the oral microbiome, which actually mom's oral microbiome is the biggest influence for babies' microbiome, actually, when they're in utero. And now we also have a ton of data on the reproductive microbiomes, the vaginal microbiome, a history of infection or chronic infection of candida, bacterial vaginosis, sexually transmitted illness. All of those can lead to inflammation that's persistent, that impairs fertility. And I mentioned also uterine microbiome. That's a bit more difficult to test. That's done through an endometrial biopsy, so it's more invasive, but there are commercially available tests that you can test, treat with an agent that is helpful to treat, and then see improvements in implantation rates. And then also the structural evaluations, which we won't cover today, but things like laparoscopy, ultrasound, HSG, et cetera. Okay. So again, when you're looking at the Dutch test, this is the summary page here. You can see the sex hormones at the top. We're not going to cover the adrenal hormones too much today. It's just kind of the outside the scope of what we can cover, but I know that Nordic has a lot of resources available for you on assessment of the HPA axis with the Dutch test. So there's a lot there for you to look at. Then you also want to make sure you're looking at that sex hormone page with androgens, progesterone, and estrogens. And then looking at the organic acids page. Don't miss that last page because it's incredibly powerful to help you understand what's going on, especially with those markers that we've talked about. I want to also suggest the Dutch cycle mapping as another option for you. If your patient has irregular cycles or symptoms that don't seem to line up with what you would expect, this is a really nice test. Instead of doing 1 day of testing, 4 samples in 24 hours, with this test, what we do is we collect about 11 samples over the course of a whole cycle. And if your patient has a short cycle or a long cycle or an irregular cycle, we give instructions for all of that. And then we can actually map the patient's estrogen and progesterone across the entire time frame. Now, the way that you'd read this is the black dotted lines, dashed lines, represent the normal range, and your patient's results show up in color. So you can see here the estradiol on top and progesterone on the bottom. The estradiol, you can see in this patient, it's coming up, but not quite as high as you might expect. It's quite low, really, throughout the cycle. And the progesterone here is climbing, but not getting super high, and it's happening too early. So what we're seeing here is that ovulation is probably happening like maybe day 12, right here, right after this estrogen surge. And so if they were trying on day 14 to conceive or day 13, they were missing the window to be able to conceive because you need to have sperm in place before ovulation. So they probably were ovulating a little bit early in this case. And there's also some hormone optimization that could happen for this patient. So the Dutch cycle map is another really fantastic test to think about using for your fertility patients. And lastly, I want to just leave you with the Dutch checklist for different patterns that you might look for that are associated with infertility. This is a real good summary of a lot of the things that we've talked about today, along with, a nice quick way for you to reference the Dutch test with those patients to really take a look at where you might look next as far as how to proceed for that patient. So thank you so much. I'm happy to take any questions. We have about 10 more minutes.
Excellent. Thank you for a very nice presentation. Yeah, a few questions came up. Actually, and just wanted to say that in VMS you can order a test that is a test pair, so it's Dutch and cycle mapping in one.
Thanks for mentioning that.
Yeah,
we offer for the complete or the plus.
Yeah. So I think I was the first person doing that because I remember me doing the test and then speaking to Mark Newman and saying like, well, you should call it the Nordic test or something.
I loved it. I actually have one upstairs in my bathroom right now that I'm collecting this cycle through. So it takes a little while, but it is a fantastic way to get a good look. And we're lucky because all the staff at Dutch, we get 2 free tests per year. So of course, I'm going to pick the most comprehensive, expensive one to do on myself. Why not? Why not see everything?
Absolutely. So one person asked in regards to the melatonin, if you would just give it every day consistently, or if you would like cycle it as well, or
Great question. So the fertility studies show using it every day can be helpful to improve egg quality, and that's really where the benefit comes from. So, we generally make enough melatonin for our own needs from a sleep perspective, but melatonin, and there's actually a really great paper published by Deanna Minnick. I'll type her name in the chat. She's a PhD researcher in the US, really brilliant. And she published a really beautiful write-up last year about melatonin kind of being the nighttime equivalent to vitamin D. Like vitamin D is the nutrient we get from sun, and melatonin is the nutrient we get from darkness. And she really ties the two together on how it is not just a sleep hormone. It has so many different broad impacts throughout the body, much like vitamin D does. You used to think vitamin D for bones, but now we know it's like vitamin D for everything, right? And melatonin probably has a cooperative relationship with vitamin D that's very much related to like our circadian patterning and how that whole system works. So I would take a look at Deanna's paper if you want to learn more about melatonin. It's beautifully written. She's like a scientist and poet. She's like a Renaissance woman, and it's really interesting. But the studies on fertility are not as eloquent. They're just giving it really more as an antioxidant. And there's really good use, really good safety studies, and really strong use to show improvement in egg quality and in pregnancy rates and live birth rates.
About the carrot study, I'll try and see if I can find it, but I just wanted to show what I picked yesterday.
Ooh. Now, when you
So-
get them fresh from the ground, it's even better because you're getting all that soil microbes as well. If you're not really scrubbing them too clean, that's great.
So now I think we need to dive a little, because the questions came in the end of the presentation. So I'm like, where should we start?
Yeah.
So you can always find like different interpretive guides in VMS under the tests. Otherwise, we'll try and link to them when we send out the recording from this webinar as well. And you can always reach out to us as well. Then Daria Ivanova is asking if the 4-hydroxyestrone in regards to fertility, if that can even affect the DNA in the egg.
So there's not data specifically on that. I think that's a really insightful question. It tells me you're really thinking about that. There's not evidence specifically on 4-OH-E1 or any estrogen 4-OH metabolite and egg quality specifically. But what we do see is those reactive quinones cause DNA damage in almost every cell type that has been studied. So I don't think eggs or egg cells or ova would be an exception to that. And when we think about the fact that our ova live as primordial follicles inside of our ovaries from birth, it makes me think about how the role of things like genetic SNPs that lead to more oxidative stress or estrogen metabolism patterns that aren't optimized when we're younger. We're living for years before we even know that that's happening. And those ova are in our ovaries already. They're not turning over. They're not skin cells that are turning over constantly. They're stored as like a germ cell. And so any exposures we have from birth affect those primordial follicles, which I think is one of the reasons why they're just so sensitive. So I think it really makes sense that they would affect the DNA. And it's something that you want to pay attention to, but there's no direct evidence to state that.
Okay, super. Thank you. Very nice answer to that question. So then Grace Kingswell asks, she has a client who has a cycle of 30 to 34 days long and skips 2 periods per year. And then this brings up the whole thing about the challenge in regards to collecting at the right time, not necessarily knowing when you ovulate, and if you only collect the Dutch plus or Dutch complete, and if you collect the cycle mapping.
That's a great question. So the cycle mapping is actually, I think, tricky for women who are skipping cycles because you don't want to have them collect the whole time and like never catch a cycle. Now, the way we do it is that we might have them collect more samples than 11, if they go 60 days without a period, when you send those into the lab, the cycle maps are a ton of work for our lab because they really want it to give you good data in difficult cases like this. They actually will find where the patient ovulated because we can see the progesterone peak, and they'll shift and only use the samples that would be related to that patient's cycle. So they shift the timing to show you a more relevant cycle map of like what it looked like, and they ignore or throw away the time points. You can still see the time point. You can see that it was like, you know, day 22 is kind of their day 1, but, or that they ovulated on, you know, day 47. You can see that noted there. You don't lose that information, but we try to plot it for you in a way to make sense. Now, the second part of your question is, could you just use the Dutch Complete in that case? And the answer is yes, you can use a Dutch Complete in that case, but you have to take a little bit of a different approach. So you want to collect Dutch Plus and Dutch Complete days 19 to 21 of the menstrual cycle, or 7 days after ovulation is a better way to put it. Let's say that for women who are irregular. So what you need to do is identify ovulation, and then, you know, 1 week later, you should be collecting. Now, there's a lot of ways you can identify ovulation. The easiest way is probably to do temperature monitoring through basal body temperature, which you can do with an oral thermometer. It's a special thermometer that measures a tighter range of normal, or a lot of devices. Like I wear an Oura Ring, I don't have it on right now. Oura Ring, Fitbit, and Apple Watches. A lot of them are now have menstrual tracking as part of it. And you could have your patient watch for the temperature shift. So when the temperature increases, that means they ovulated 1 day before that temperature spiked. And so it's 6 days after the temperature increase that they would collect. That's my favorite because it's like easy. Now, the other thing some patients do is they use ovulation predictor kits, which you can buy off the web as just like a paper strip rather than the full plastic piece that you might buy at a pharmacy. You can get them a lot less expensive, but you would pee on that every day, wait for it to show up, and that shows an LH surge, which is generally 1 day before ovulation. So when you got a positive OPK, you would test about 8 days later. Now, those aren't perfect because some women will have LH surges, but they won't ovulate. And a positive OPK does not mean ovulation happened, right? The temperature shift is our best at-home method, or progesterone measurement, but you wouldn't really want to do that. You know, that's a little bit invasive. So I think the temperature monitoring is the easiest way in patients who are irregular. That way they can just watch to see when their temperature shifts and then do the test 7 days later. And that's a pretty reliable way to catch that mid-luteal phase. We get that question all the time. It's like such a great question. It can be so challenging to try to identify the right time.
Then another question came up, and it may take a little bit, but why dried urine and not saliva and not blood? But yeah, that's a question you get a lot, but still maybe important here.
It is. And maybe we can do that as another webinar, because that is such a common question. And I think that we are not the hammer for all nails. If you talk to like Mark Newman, or you talk to anyone on our team, we will tell you when Dutch testing is not the best option. One great example is testosterone. We think the Dutch test is a great way to augment understanding testosterone, but serum is best because there are patients that have a genetic SNP that makes it so they don't spill testosterone into urine. And that makes it so that it's really tough to get it out of urine, right? But there's other things that we do really, really well. Now, there's a couple benefits to serum. One, there's the most data on serum for the most part. I would say that. But serum is only a snapshot in time. And remember, hormones are like this all day long. And for a menstrual cycle, of course, there's wide variations. If you've ever done like an estrogen test on a woman, it'll say like the follicular phase normal is like 13 to 450, right? It's like so broad that you have no idea how to interpret that. So that can be a challenge with that. And it's only a single snapshot. With the Dutch, it's 4 time points over the course of a day. So you're getting an average hormone level over the course of 24 hours, which is a lot more, it's helpful because you're not likely to catch a high or a low. We can kind of even that level out. Now, saliva, I used to test saliva before I tested Dutch. And even when I started working at Dutch, I didn't have a strong opinion for or against. But now that I've read the data on saliva measurements for hormones is very poor. It's lacking data there, but Dutch, we actually have validated and published our validation to say it correlates with serum. There's no such studies for saliva. And the studies that have been done on saliva show it to be a pretty poor indicator. There was one study, I was just looking at it yesterday for another presentation. It's called Not Within Spitting Distance. You could look it up, Not Within Spitting Distance, saliva, serum, testing, hormones, whatever. And what they found was that testing progesterone was a little bit better, but with estrogen, it was so bad that you were better off to flip a coin to guess whether a woman was in her follicular or luteal phase than you were to measure saliva, because saliva was so misleading. So it's an area that I'm really passionate about, and that's in women that are menstruating. So that's when levels are higher. When you get to peri and postmenopausal females, the levels are so low in saliva that it becomes much, much more difficult to get accurate measures. So there's just a lot of challenges with saliva. It's not something that I think has advantages over serum or urine, really in any circumstance other than cortisol, which saliva is the gold standard because it so quickly enters the saliva that you could do a CAR in the morning where you can get 3 time points in the first hour to measure the cortisol awakening response. And really, saliva is the gold standard for cortisol. But for reproductive hormones, it does not appear to really be the most effective place to measure, both with natural production as well as with hormone replacement.
Excellent. Now, time is up, and I think you need to go and look after yourself.
Yeah, I know. I'm so sorry. I'm like coming down with a cold and
Oh, you've been done excellent.
You've
done excellent. I just felt a little bit sorry for you. So thank you everyone for hanging in there. And as already mentioned, a little bit like we are going to have coming up webinars. We've made some great agreements with Dutch testing so that you will continue getting educated in the test. And for those of you who are in Copenhagen in the weekend 1st to the 3rd, you will also meet Dr. Carrie Jones in person, because she will join us and do some education there as well. So yeah, we're all excited about Dutch test and Dutch education. So, and we of course will share as much like educational material that we can over the next period of time. We are, of course, a little bit under pressure right now because we have some events coming up right now. But once that period is over, we'll just start sharing what we have. But we'll share the webinar now, the recording, and Dr. Smeaton will also share her slides. So we will share that with you as well as soon as possible. And then there's a few heads that just entered, and that's probably a time difference challenge because the webinar is ending now, but we will share the recording. So to all of you, thank you for attending. What a fantastic group you all were, and thank you for all the questions and like engaging. Take care. Bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.